Okay, back to Integrated Rehabilitation Group with Health Matters. We're continuing the Ask the Surgeon segment, a little bonus Ask the Surgeon brought to you by Everett Bone and Joint. Dr. Jeff Mason, Dr. Doug Nowak, Dr. Clay Wertheimer. So let's talk about Achilles tendons.
Yeah, let's talk about that. Who wants to start by explaining the Achilles tendon? Give us an anatomical picture. Where is it located? What does it do? What's its function?
I'll take that one. The Achilles tendon, first of all, a tendon is a thing that connects a muscle to a bone. So the muscle in your calf is actually made up of two muscles called your gastroc and your soleus, and that makes up your calf muscle. And it attaches to your heel bone via the Achilles tendon. And it's the mechanism by which we are able to stand on our toes, or that we use to jump or push off to generate a jump or a fast run. So it's really important in the function of your leg.
Okay.
So what causes it to rupture? And I've seen this happen to people before, and they just drop like they've been shot.
Yeah, it's kind of the same process that causes this paunch that's hanging over my belt right now. It's called getting old.
Yeah, there you go. That's right.
Oh, I'm familiar with that.
Basically, getting old and being male is probably the two most common characteristics of people that rupture their Achilles tendon.
Is there a certain age range? I've heard there's a kind of a spike in ruptures.
That's right. Probably between the 30s and 50s of those guys, particularly guys that have been out of shape for a while, and then they decide they're going to go to the Y and play some hoop.
Exactly. I was just going to say that.
Yeah.
I've seen them
before.
Or
they decide in the summer, oh yeah, I'm going to get back on that slalom ski and water ski, or I'm going to take up tennis again, and they're out of shape. Their calf muscle may be tight or constricted and a little bit weak, and they get out there and do something what we call ballistic. All of a sudden they push off, and typically they'll say they thought they got hit by a baseball bat.
I've heard that before, right in the back of the leg.
Right in the back of the leg.
But they generally kind of go down really quick. They kind of drop, don't they?
Yeah, it's really painful.
Is it painful and also kind of scary? And then let's talk about, so if you have a rupture, you can have a complete rupture and a partial rupture. And what is the surgical or treatment approach? Let's start with a partial tear. Who wants to grab that?
Well, I don't want to say start with a complete tear, because it's still even a controversy with how to treat a complete tear.
Okay.
Because complete tear can be treated in two ways. You can do it surgically, where you surgically put the two ends back together and use a suture to tie those ends back down together. Or you could do a serial casting, where you mobilize the leg in a certain position, the ankle in a certain position, to allow those ends just to heal up with time. And the reason I say it's controversy is because there's been a few studies looking at comparing the two treatment outcomes, and they find in many measures they're actually very comparable. Surgery does have certain advantages, that it does give you a little more strength to your push-off. So you're trying to raise up on your heel or do some sort of explosive maneuver like that. Some studies have shows that you get slightly more strength. It also has a lower re-rupture rate, meaning tearing it again. So if you were to treat it in a cast, you're more likely to tear it again if you try to get back to activities compared to surgery. Now, in certain patients, a non-surgical approach is preferred. Someone who's older, or maybe they smoke, because smoking impairs wound healing, increases chances of having complications with surgery, or someone that may have certain medical problems like diabetes, they typically will recommend to do a non-surgical approach. But in a young, active person, most orthopedists would recommend to have it fixed surgically. And
is that kind of just the surgeon's preference, and is it based on what kind of activity that patient wants to get back to and how quick they want to get back to it? So, because how long, Dr. Mason, how long do you have to cast someone versus getting them into rehab with post-surgery?
Probably the entire time frame of the treatment would be fairly similar in that if you repair someone surgically, for a certain period of time you keep them non-weight bearing or partial weight bearing if they're able to comply with that, and then you start physical therapy. It depends on the condition of the tendons. Occasionally people will have a very clean rupture and you feel you have a very stout repair. Most of these, when you look at them, though, it's quite interesting because you'll have a patient who says, I felt fine till the whole thing blew up. And then you go and look at the tissue and you say, well, this tissue's obviously been, getting damaged, falling apart, et cetera, et cetera. So, but literally about 10% of all ruptures, or particularly partial thickness ruptures, or people who show up with an obvious tendonitis, are people who can report an event. 10% of them can say it happened and now I've had problems. But more often, people, whether they rupture or develop symptoms, they say, I don't know where this came from. It's either a sudden occurrence in the case of a full rupture, or if they have a tendonitis, they'll say, gee, I don't know.
Just kind of snuck up on them.
Snuck up on me.
So interesting. So what's your choice, Clay? I mean, you've been at this a little while. I mean, no offense there, but do you have any kind of opinion?
Well, like Doug said, I think in someone who's high demand, who's really active, who wants to make either a career or has a big commitment to things that involve pushing off, playing basketball, playing tennis, and who doesn't have diabetes, who's not a smoker, then, yeah, my opinion is that fixing it is the best way to go. There are all sorts of controversies involved in how you fix it and then how you treat these patients after you fix it. How you fix it, there are some people that do minimally invasive, almost percutaneous, and take the sutures through the skin, don't make an incision. Other people make a big incision. Some people put a graft in, other people don't. So there's a lot we don't know, and there's not a lot of good science that's demonstrated one technique is better than the other. Personally, I think that putting the thing back together in a high-demand person makes sense, but in a lower-demand person or someone like Doug said who have these other medical problems, then non-operative treatment is really sufficient and works fine.
So what about someone that you suspect has a partial tear? It's just a chronic problem. I mean, would you call that a tendonitis or a tendinosis or
a tendinopathy?
Or
any
tendinopathy.
Of those terms.
Okay. And treatment, talk about that, Dr. Mason.
Well, there are a whole bunch of different things you can contemplate. Things like physical therapy can be useful. Some people say it's effective. Other people say it's not. A lot of people will say that eccentric muscle contraction work for a tendinopathy is more effective than concentric contraction, and that's been suggested. But there are all things like corticosteroid injections. Well, that's dangerous if you inject into the tendon. Some people have shown that if you're able to inject near the tendon, it can reduce inflammation. But it's typically a prolonged process because normally people have had some degenerative process occurring, and when it finally becomes symptomatic, they have lots of symptoms, lots going on with the tendon. And there are even surgical procedures for tendinopathies where people will try to, partially divide the tendon or cut the tendon longitudinally, try to stimulate blood flow. And it's like a lot of these things. All of these things work pretty well a lot of the time, but they have a high enough incidence of not working well that we really feel that more information will be developed.
Is there a chance of rupturing from the little tear? I mean, would it progress?
Probably, yeah. But
the
people that present with tendonitis, with kind of the chronic nagging progressive pain in the Achilles, are really different than the people that present with a rupture.
Right.
I mean, like we were saying earlier, the most common rupture is a guy that's out of shape, that has suddenly wanted to do something.
I'd fall in that
really
category.
high.
That sounds like you're talking about me, Clay.
But the people that present with a chronic nagging pain, they're actually kind of two groups. One is a young athletic runner type that develops, microscopic tears in the tendon from a training error.
But then you're going to call that microscopic tearing tendonitis.
Yeah.
Or
so
tendinopathy.
Itis means inflammation.
Right.
So they get the chronic inflammation in there. And then there's the older folks, too, that develop what's called insertional tendonitis, where the tendon inserts onto the bone. Over time, they can develop bone spurs and get chronic inflammation there, like a pump bump. But it gets really, really bad. And so those two different groups have really different demands and often different treatments. The young, active person, you got to figure out what their training error is, get the inflammation simmered down, and look for underlying causes like if their calf muscles are too tight, it could be actually promoting damaging the tendon by tugging on the tendon too much, too fast, too frequently. Whereas the older person, it may be a change in shoe wear, put them in a cast, rest them, and if it's really, really bad, then we'll take the bone spur out and repair the tendon after we take the bone spur out. So.
Now, what do you all think about immobilization? Put them in a boot for 6 to 8 weeks for someone who has maybe that chronic tendonitis, just stopping the movement of that tendon and letting the body heal. Does that work? In your opinions? There's kind of everybody's rolling their eyes and everything.
It really depends again on the group you're talking about. For that young active person, I mean, there's some pretty good evidence, at least in animals, that if you immobilize things for more than a couple weeks, it goes bad.
Okay.
You get muscle atrophy. the tissue breaks down. So,
but that's the new thinking, though, isn't it? Though, Clay. I mean, years ago, wasn't it bed rest and just stop all activity? Now,
yes.
I mean, the thought is that immobilization aspect of it actually causes more problems.
Yeah,
I mean,
so. What's your take on that?
Yeah, I mean, early motion in multiple studies in different parts of the body has been shown to be beneficial to injuries, whether you're treated non-operatively or with surgery. In the 70s, after a lot of surgeries, you'd put someone you'd fix an ACL, you'd put them in a long leg cast for like 6 weeks.
Yeah.
Now, let's say the hip arthroscopies I'm doing, you get patients up on a stationary bike the day of surgery, the day after surgery. We want them to start using it at a low resistance level. So we want to get motion, but not necessarily a lot of force across the joint. And then what that does is that helps in the joints. It allows the synovial fluid, which is the fluid in the joint, to bring the nutrients to the cartilage and other structures in the joint to help them heal properly.
And is recovery time quicker because of this?
Well, it's hard to say. No one would ever do in order to definitively say that, you need to do a study comparing one method to another.
Right.
No one nowadays would do an ACL reconstruction, put them in a cast for 12 weeks versus move them the next day.
Yeah.
So, yes, we think that it is. We can't say that 100% certainty, but I'm fairly confident that our recovery is much quicker with this earlier motion.
When we talk about signs and symptoms, I mean, when should someone assume that they have a partial tear of their Achilles? I mean, obviously we talked about the complete rupture. You're going to know that. You're going to hear a pop. You're going to feel like someone took a baseball bat and hit the back of your leg. What about that chronic problem? I mean, what's your recommendation again? When should they see folks?
Well, it's an interesting way to put the question, because I think what we're sort of ending up talking about here is you can have a diagnosis like Achilles tendonitis or rupture, but in reality, when these people come into your office, you find that there are classic groups and groups between the groups, and you're sort of saying, what really is the issue here? Because you'll have people come in and they'll develop symptoms, and they have this low level of activity. They walk around a bit in the shopping mall or at work, and they've got a raging Achilles tendonitis, and that's a very different creature from the person who's got it through athletic training or mistraining or has an acute injury. And so you sort of spend your time saying, what do I have here? Partial tears can sometimes be uncovered with physical examination where there's a defect, but more often a partial tear is this sort of thing where you finally are baffled enough by how it's behaving that perhaps you'll get an MRI and you'll say, oh, lo and behold, there's a partial tear here. And then you have to decide what to do about it, because you're not so much concerned about the fact that maybe 10 or 20 or 30% of the tendon is torn. What you're concerned about is what the rest of the tendon looks like.
Right.
I think for your listeners, I mean, if their Achilles is hurting them and they've backed off on that activity that's hurt them, and they've rested for a week to 10 days, and they've taken some anti-inflammatories, and it's still hurting them and keeping them from doing what they want to do, that's the time to get seen and get checked out. And I think also something to say about prevention is important.
Right. Yeah.
That if you are like me, you got a little paunch hanging over your belly, and you're thinking about going out back and playing basketball with your buddies, get in shape before you and progressively get in shape before you go out there and start taking up things like tennis and running and basketball and ramp yourself up, and also stretch out and also
prior to the activity.
Yeah,
warm up, stretch out.
Warm up, stretch out. And particularly if you are prone to having Achilles problem, or you've had Achilles tendonitis in the past, be sure to stretch out those muscles in the back of your calf before you take off on your jog or your bike ride or your basketball game.